Every 10 minutes, somewhere in the world, someone loses enough central vision to stop reading, stop driving, and stop recognizing faces. Not because the disease came out of nowhere, because the disease gave them warnings for months, sometimes years, and nobody ever taught them what those warnings look like. Macular degeneration is now the leading cause of irreversible vision loss in adults over 50 in the developed world. More than glaucoma, more than cataracts. And unlike cataracts, you cannot fix it with a 20-minute surgery and go home seeing clearly that same afternoon. The damage it causes is permanent. The window to act is before the damage happens, and that window is wide open for longer than most people think. Here is what the research actually shows. Age-related macular degeneration takes years to build. It does not appear one morning fully formed. It progresses through distinct stages, and at every stage, your eye is sending out signals that are specific, recognizable, and completely different from normal aging. The problem is not that the signals are subtle. The problem is that nobody ever told you what you're looking for. That changes today. Subscribe to Senior Health right now and hit that like button. We are working toward 200,000 subscribers, and every single one moves us closer to the goal of this channel, which is giving you the medical information that the system has no financial incentive to hand you for free. Before we go into the 4 signs, I need to demolish one myth that is actively costing people their vision. The myth is this: if something changes slowly, you will notice it. That sounds reasonable. It is completely wrong. Your brain is one of the most aggressive compensation machines in the known universe. When one part of your visual field starts to degrade, your brain quietly reroutes processing. It fills in the gap. It uses context from the surrounding image to reconstruct what it assumes should be there. You are not seeing what your eye is actually delivering. You are seeing what your brain has decided to show you based on a combination of real input and prediction. This is called neural adaptation, and it is the reason people with significant macular damage still pass a standard eye chart test at their annual checkup and walk out thinking everything is fine. By the time you consciously notice a problem with your central vision, the macula has typically already lost a meaningful percentage of its photoreceptors. Those cells do not regenerate. This is not like muscle you can rebuild or cartilage you can slow the loss of with movement. Photoreceptors lost to macular degeneration are gone. This is why the 4 signs I'm about to walk you through matter so much. They appear before the photoreceptor loss becomes irreversible. They are your window. Let me first give you the anatomy in plain language, because understanding what the macula actually is makes every sign make more sense. Your retina is the thin sheet of light-sensing tissue lining the back of your eye, like the film inside a camera. The macula is a small specialized zone right at the center of the retina, roughly 5 to 6 millimeters in diameter. Small enough that if you held a coin at arm's length, the macula would be processing the light coming from an area roughly the size of that coin. But that small zone is responsible for all of your central high-resolution vision. Reading, recognizing a face, seeing the expression on someone's face across a table, seeing the number on a bus, threading a needle. Everything that requires detail goes through the macula. The macula is densely packed with a specific type of photoreceptor called cones. Cones are the cells that give you color vision and fine detail. The center of the macula, a tiny pit called the fovea, has the highest cone density of anywhere in the eye. It is responsible for the sharpest slice of what you see. Underneath the photoreceptors sits a layer called the retinal pigment epithelium, or RPE. The RPE is essentially the support system for the photoreceptors. It feeds them, clears their waste, and maintains the local environment they need to function. Below the RPE is a membrane called Bruch's membrane, and below that are the blood vessels of the choroid, which supply the outer retina with oxygen and nutrients. Age-related macular degeneration begins when this support system starts to fail. Waste products from the photoreceptors accumulate faster than the RPE can clear them. Those deposits build up between the RPE and Bruch's membrane. Researchers call those deposits drusen. As drusen accumulate, the RPE cells are compromised, and eventually the photoreceptors above them lose their support and begin to die. In a subset of people, the disease then takes a more aggressive turn. The body, detecting that tissue is not getting enough oxygen, sends a signal to grow new blood vessels into the area. But these new vessels are abnormal. They leak fluid and blood. This is called wet macular degeneration, or neovascular AMD. Wet AMD progresses much faster than dry AMD and can cause severe vision loss in weeks to months if not treated. The critical point is this: all of that groundwork is laid during a long phase when the eye is giving you signs. Signs that are not inside your eye, they are in what you see with your eye. They are perceptual. You can check for them yourself. And they consistently appear before the damage becomes catastrophic. Here are the 4 signs. The first sign is that straight lines begin to look wavy or bent. You are reading the newspaper. You look at the edge of the page, or at a line of text, or at a door frame across the room, and it looks slightly curved. Not dramatically, not like a funhouse mirror, just slightly off. A gentle undulation where you know there should be a clean straight line. You blink, you look again, and maybe it seems fine. You decide you need new glasses, or you were squinting, or the light was bad. What is actually happening is this: the macula is not a single monolithic sensor. It is a mosaic of individual photoreceptor cells, each sampling a tiny point in your visual field. Your brain assembles those individual samples into a continuous image, the way a mosaic of tiles becomes a picture when you step back. For that assembled image to look geometrically accurate, the photoreceptors need to be in their correct positions. When fluid accumulates under the retina, whether from drusen pushing up from below or from leaking new blood vessels in wet AMD, that fluid physically distorts the architecture of the photoreceptor mosaic. Individual cells get pushed out of alignment. When light from a straight edge hits that distorted mosaic, the brain assembles a bent version of the line. Because the sensors feeding it the information are no longer geometrically calibrated. This phenomenon has a clinical name: metamorphopsia. Metamorphopsia simply means distorted shape perception, and it is one of the most specific early indicators of macular pathology in existence. Here is what makes this sign actionable. There is a test you can do right now in your home in 30 seconds. It is called the Amsler grid. It is a simple grid of perfectly straight horizontal and vertical lines with a dot in the center. You look at the dot with one eye while covering the other. Any area of the grid that appears wavy, bent, blurry, missing, or discolored is a red flag for macular disease. Optometrists and ophthalmologists use this grid as a standard screening tool. Macular disease research groups recommend that adults over 50 do this test at home regularly, covering one eye at a time, because the brain's compensation effect means that when both eyes are open, the healthy eye can mask what the affected eye is seeing. The test only works one eye at a time. If you notice any distortion on that grid, that is not a reason to panic. It is a reason to contact an eye care professional urgently and ask specifically about macular imaging. The word to use is OCT, optical coherence tomography. That imaging test can detect fluid accumulation and structural changes in the macula long before any other test picks them up, and it is the standard of care for macular degeneration monitoring. The second sign is that your central vision becomes noticeably dimmer, especially when moving from a bright environment to a lower light environment. You walk in from outside on a sunny afternoon and step into a moderately lit room. You need more time than you used to before things look normal. Or you sit down at a restaurant in the evening and the menu feels darker than it used to, even though the lighting has not changed. Or you find yourself turning lamps on during the day when you never needed to before. Here is the mechanism. Vitamin A deficiency is one well-known cause of poor dim light adaptation. But in the context of macular disease, the mechanism is different. The photoreceptors in the macula, under chronic stress from drusen, fluid, or compromised RPE function, begin to lose their sensitivity. They require more light energy to generate a reliable signal. The visual system's ability to adapt to lower light levels depends on both the health of the photoreceptors and the speed and efficiency of the chemical cycle that resets them between exposures. When those cells are under stress, both their sensitivity and their recovery speed drop. You do not notice it in bright light because in bright light there is enough energy coming in to overwhelm the inefficiency. You notice it at the threshold where normal vision and low light vision overlap. That transition zone becomes sluggish. Things look dimmer at light levels that used to feel normal. What makes this sign important is that most people attribute it immediately and exclusively to aging. And aging does slow dark adaptation to a degree. But there is a meaningful difference between the gradual, symmetric, bilateral slowdown of normal aging, which affects both eyes roughly equally and progresses very slowly over decades, and the kind of dimming that is driven by early macular disease, which can be asymmetric, meaning one eye affected more than the other, and which can progress over months rather than decades. The self-test for this sign is simple and takes 30 seconds. In the familiar room, with your usual lighting, cover your left eye and assess how bright and clear the room looks with your right eye alone. Then cover your right eye and do the same. If one eye consistently shows you a noticeably dimmer, grayer, or less saturated version of the same room, that asymmetry is worth reporting to an eye professional. Not blaming on the overhead light bulb, reporting to an eye professional. The third sign is that colors in your central visual field begin to look less saturated, or that a grayish or washed out patch appears in the center of your vision when you focus on something. You are looking at a fruit bowl. The oranges look slightly muted, not gray, but less vivid than they used to look. Or you look at your partner's face and there is a slight haziness right in the center, where you are trying to look directly. You focus on it and it seems to clear, but then you notice it again. If you look slightly to the side of their face, you can see them clearly. But when you try to look directly at them, something is slightly off in the dead center. This sign has a name in ophthalmology, a scotoma. A scotoma is an area of reduced or absent vision in the visual field. Early scotomas in macular degeneration are often relative rather than absolute, meaning the area is not completely dark. It is just dimmer, hazier, or less color-saturated than the surrounding field. Because it is relative, the brain's fill-in mechanism works overtime to patch it, and you often do not notice it consciously unless you are specifically looking for it. The reason colors are affected early is that the cones, the color-sensing photoreceptors concentrated in the macula, are the first cells to be affected by macular disease. Color processing is macula-dependent in a way that peripheral vision is not. When the cone layer starts to lose function, the first subjective experience is often a reduction in color vividness rather than a reduction in acuity. Many people who have later been diagnosed with early AMD report, when looking back, that color television looks slightly less vivid on one side of their vision compared to the other, months or years before they noticed any change in sharpness. They had attributed it to the television or to fatigue. It was their macula. Again, the self-test is one eye at a time assessment. Look at the uniform, brightly colored surface, a solid color wall, a clear sky, a painted door. Cover one eye. Does the color look the same intensity to both eyes? If one eye consistently shows you a slightly faded or grayed version of the same surface, that is worth investigating. The fourth sign is a significant increase in difficulty with reading tasks that cannot be explained by your glasses or contact prescription. You had your prescription updated 6 months ago. Everything was fine. Now reading feels harder. You need more light. You need to hold things slightly further away, even though your prescription was correct for the distance you are holding them. Small print that you could read without difficulty now requires more effort and more time. After a page or two of reading, you feel a fatigue in the eye that is different from the usual tiredness of a long reading session. It is more of an effortful, strained quality. What is happening is that the density of functional photoreceptors in your central macula is decreasing. Reading is perhaps the most demanding task your macula performs. It requires rapid, precise, sequential sampling of small, high-contrast details across a line of text. It requires the fovea, the highest resolution zone in the eye, to be functioning at full capacity. When the fovea begins to lose photoreceptor density, reading degrades first, before any other visual task, because it has the least margin for error. You can compensate for a 10% reduction in peripheral resolution and never notice. A 10% reduction in foveal resolution, the area responsible for reading, is immediately apparent in the most demanding task that area performs. This is also why standard eye chart testing is so inadequate as a screening tool for early macular disease. The letters on an eye chart are large. They are high contrast. They are isolated. They do not require the rapid sequential processing that reading does. People with early macular damage routinely pass standard acuity charts because the fovea still has enough functional cells to identify large isolated letters, but not enough to sustain comfortable, fluent reading. If you have ruled out a prescription change as the explanation, if you have ruled out dry eye, if you have ruled out inadequate lighting, and if reading is still noticeably harder than it was 1 year ago, that is a conversation you should be having with an ophthalmologist, not an optometrist. And the specific examination you should be asking about is a dilated fundus exam plus OCT imaging of the macula. Let me now bring all 4 signs together so they are clear in your mind. Straight lines appearing wavy or bent when you know they are straight. That is metamorphopsia, and it reflects physical distortion of the photoreceptor layer. Increased dimness or longer adaptation time when moving between light environments, especially asymmetric between the 2 eyes. That reflects reduced photoreceptor sensitivity and slower chemical recovery cycles. Reduced color saturation or a grayish haziness in the center of your visual field when focusing directly on something. That reflects early cone cell dysfunction and the beginning of a relative central scotoma. Unexplained reading difficulty that persists despite a correct prescription, adequate light, and no other identified cause. That reflects foveal photoreceptor loss in the zone most critical for fine detail processing. None of these signs requires you to be seeing dramatically. None of them requires a dramatic event. They are all gradual enough to be ignored and subtle enough to be rationalized away. That is exactly why I am telling you about them now, before any of them has had a chance to become irreversible. Here is what you do after this video. First, do the Amsler grid test today. Cover one eye. Look at the central dot with the other eye from about 12 to 14 inches away, roughly the distance you hold a book. Look at the dot, not at the grid. In your peripheral awareness, does any part of the grid appear wavy, missing, discolored, or blurry? Switch eyes and repeat. If you notice anything abnormal, call an ophthalmologist this week and use the words macular evaluation and OCT imaging. Second, do the color saturation comparison test. Look at the uniformly colored surface with one eye, then the other. Note any asymmetry in color intensity or any central gray haziness. Third, if you have not had a dilated eye exam with a qualified ophthalmologist in the last year and you are over 50, schedule one. A dilated fundus exam is the only way to directly visualize the condition of your retina, including the macula. It takes about 30 minutes. It is not painful, and it is the single most effective tool for catching early macular changes before they become irreversible. Fourth, ask specifically about your risk factors. Age is the primary one. Smoking doubles the risk of AMD and accelerates progression in people who already have early disease. A family history of macular degeneration in a parent or sibling meaningfully increases your own risk. Cardiovascular risk factors, particularly high blood pressure and elevated inflammatory markers, are associated with faster progression. These are all things your ophthalmologist can use to determine how frequently you need monitoring. There is also a dietary factor that has consistent evidence behind it. The AREDS2 formulation, a specific combination of vitamin C and E, zinc, copper, lutein, and zeaxanthin, has been shown in large randomized controlled trials to reduce the risk of progression from intermediate dry AMD to advanced AMD by approximately 25%. This formulation is not a treatment. It does not reverse existing damage, but in people who already have drusen and intermediate stage disease, it is one of the few interventions with solid evidence behind it. Talk to your ophthalmologist about whether it is appropriate for your stage of disease. If you are diagnosed with wet AMD, meaning there is active fluid from new abnormal blood vessels, there are now highly effective treatments called anti-VEGF injections. These injections, delivered directly into the eye under sterile conditions, block the signal that drives the growth of those abnormal vessels. They do not feel as alarming as they sound. Most patients describe minimal discomfort, and in clinical trials, they stabilize or improve vision in the majority of treated patients. The key word is stabilize. They work best when the disease is caught early, before significant scarring has occurred. Every month of delay in treatment is a month during which those abnormal vessels can cause additional permanent damage. This is why the 4 signs matter. Not because knowing them turns you into a diagnostician, but because recognizing them triggers the right action at the right time with the right specialist using the right tools. The healthcare system does not have a billing code for the conversation I just had with you. Your next annual appointment will almost certainly not include the Amsler grid test, the color saturation comparison, or a careful question about reading difficulty. The system is built around treating disease once it is established, not around equipping you to catch it in the window when it is still modifiable. That is the entire reason this channel exists. Subscribe to Senior Health and hit like. It takes 5 seconds and it helps us reach more people who need this information before it is too late to act on it. Drop your age in the comments below. It helps me understand who is watching and build the content that actually speaks to where you are.